Thank you, Chairman, sir. Thanks to the organizers for giving me this opportunity. The red knee, when to worry. What are we worried about? I think Mohanty just talked about PJI, so that is the worry, that the prosthetic joint may get infected. Around 1% is the registry data of infections, early infections, and if you follow these patients up, it is 0.07% late infections per year after 2 years. So that is the rate of infection in the world literature. So should you worry? I would say worry always if you do not know what you are supposed to do, or never worry if you follow the principles and you know what you are supposed to do. So what you should never do is fail to counsel the patient or the relatives, or use antibiotics and higher antibiotics without a diagnosis. What you should do is forewarned is forearmed. So talk to your patients beforehand also that these things do occur, although uncommonly. So pre-op counseling is important, and explain the precautions that you are going to take, the patients have to take, the OT takes, so that the likelihood of this gets minimized. There is an interesting article from the Parvizi group, and I advise all of you all to read intraoperative and post-operative infection prevention, and we should all follow this. And briefly what it says is that although pre-operative is not covered in this, that patient optimization, check that his hemoglobin is okay, diabetes is controlled, nasal decolonization for staph, reducing the skin flora by chlorhexidine gluconate baths, whatever you can do to optimize the patient pre-operatively should be done. Intra-op, use antibiotics IV but not for more than a day, reduce the surgical time, OT traffic, dilute betadine irrigation helps, don't use drains, ensure normothermia. There is no real evidence that laminar airflow and personal protection kits that we routinely use, helmets and all, reduce the rate of infection, but we still tend to use them. Post-op, use occlusive dressing. Silver impregnated dressings are found to be useful. If required, use negative pressure wound therapy for earlier healing. Blood transfusions may be avoided if possible. Use anticoagulation judiciously, and aspirin may be an answer. And early care of hematoma, drainage, or early wound dehiscence. So post-operatively, when you see an abnormal wound, it could be bruising, hematoma, skin necrosis, persistent wound drainage, or early sepsis. Post-op bruising may appear alarming, typically after the 3rd, 4th day, settles over a period of a month, not associated with undue pain, and commoner when drains are not used. Post-op hematoma, blood thinners may be the culprit, can be painful. If you aspirate the knee is full of RBCs and looks like blood only. If there is a wound breakdown, you may use this WAC as it is commonly said. But if there is early sepsis, the patient generally complains of undue pain, loss of regained knee range of movement, there may be redness, there may be persistent wound drainage, or there may be wound breakdown. If you see purulence, then you are really very, very late. So diagnosis of early sepsis is critical, treat before it becomes chronic, and objectivity of the various signs become important, what you see for early sepsis. So there is no guidelines regarding intervention according to how much is it red, how much is the loss of movement, how much is the pain. Wound breakdown, obviously you would treat aggressively to get it to heal. But persistent wound drainage after a total joint arthroplasty has guidelines. And I advise all of you all to read this 2018 paper, where they have classified wound drainage into limited, moderate, excessive, or massive, depending upon how much is the soakage on the gauze pieces which is present on the wounds. So this would classify as excessive persistent wound drainage. Pearls from this paper: if there is category 4 drainage, debride early, even by the 7th day. can observe category 1, 2 and 3 drainage until 2 weeks if clinically sepsis is not suspected. If drainage plus sepsis is suspected, debride early before 2 weeks. Observation of persistent wound drainage, dressing, stop physiotherapy, correct nutritional factors, modify anticoagulants, serial serological markers and chase the patient. Early sepsis, think in any patient who deviates from normal course, investigate. If it appears septic, intervene early. Differentiation between bruising, hematoma and infection can be difficult. Do ESR, CRP and aspiration when in doubt. You may do aspiration in clinics. Look for the WBC per millimeter cube and percentage of PMNs. Again, a paper in the Journal of Arthroplasty where they have said if synovial WBC is less than 12,000 with less than 70% PMN, unlikely to be infected. More than 16,000 with 90% PMN, likely to be infected. CRP less than 34, not infected. More than 74, infected. In between values, use your clinical judgment. Once you operate, uneventful wound healing is your moral responsibility. Extra care for any deviation from normal healing, whether it is red, blue, black or green, finally it is your baby. If you think of sepsis, do early DARE. Involve the patient, treat according to established principles, be concerned, empathetic, I would say don't worry, and do DARE in early cases. I thank you for your attention.